Scott, and while we're on the subject, of course, we have the Arches trial, the Latitude trial, the most recent Aeronote trial. A lot of these trials, there were some slight differences in them, but they're looking at least in terms of the Arches and the Latitude, looking at enzalutamide or abiraterone and prednisone versus observation with ADT in these metastatic castrate-sensitive prostate cancer in that space. Do you, I say on the Latitude trial with the abiraterone, the primary endpoint was overall survival, and they met that. On some of the other trials, they used radiographic progression-free survival as their primary endpoint, like especially with the Aeronote with the darolutamide. My question is, a couple of questions. One, how do you decide which one of these second-generation anti-androgens you might use? And the other question that is sort of a broader question that I'll ask all of medical oncologists is, how do you assess radiographic? Is radiographic progression-free survival meaning changes in imaging, conventional imaging on these trials, not PSMA? Is that meaningful, or is really the overall survival number the best? So really, which drugs do you choose, and why, based on these trials? And
I'm not honestly sure that the trials give you a clear winner and who to pick between abiraterone or enzalutamide or darolutamide. I think most of us think that they're probably pretty similar.
Is the side effect profiles pretty similar?
No, they're not. I mean, that's what so it's not necessarily the efficacy that makes the decision. Sometimes it's comorbidities. If they're diabetic, then, I don't really want to use the prednisone with it. If they have a history of seizure or something, maybe I'll stay away from enzalutamide. Number of pills sometimes matters. I probably tend to use more of the apalutamide, darolutamide than I do abiraterone. I don't do a lot of imaging as long as the PSA is under control. And if I start to lose control of the PSA, then I'll image. But I'm not sure radiographic progression matters that much to me.
Okay. Even though some of the trials, that was their primary endpoint.
Yeah.
And what do you think about that, Jose?
Well, I think, I think if you're talking about like high volume disease, right? So you know that the data is going to be with darolutamide and abiraterone with chemotherapy as the backbone and ADT as the backbone, right?
Then we'll get to the Arisons.
Right. And so I think for high volume disease, those are going to likely be my go-to. I think darolutamide, in terms of its toxicity profile, it's very well tolerated. So I think, it has very little CNS penetration for something that's the patient's going to be on long term. I think that's typically my go-to in terms of high volume. In terms of, the abiraterone, I tend to shy away folks who have maybe fatty liver disease, who have metabolic syndrome, because that's going to require steroids. I think when you're talking about low volume disease, and I think at that point, then you're really picking based on side effect profile. I think if, when you look at things like apalutamide or enzalutamide, in my opinion, it's probably not going to be the best drug for elderly folks because of the fall risk. And so then I'm typically going to go with, abiraterone and, darolutamide I think it's recently got approved for castrate-sensitive. So I think you can throw that in there. And so I think that's how I tend to look at it, high volume in the things that are approved. And then I look at side effect profile and just try to match it to the patient's comorbidities. Obviously, there's things outside of that, which are going to be cost, insurance coverage, which always factor into our decisions, unfortunately. So those things. In terms of the radiographic progression, you tend, or at least I tend to look at radiographic progression as an important, because it is prognostic, as opposed to the PSA. If the PSA is rapidly increasing over to where they do meet PSA progression, there's other concerning things that may not be evident. Maybe, they're bone marrow function is starting to fail because maybe disease progression's in there. The performance status is telling me that is disease progression that is going to make me want to switch sooner rather than later. But I think that in our practice, in terms of research, because that's kind of one of our big programs, is that we want to try to stay as faithful to that so that patients can qualify for trials, so that you don't take away options. And so I think by and large, again, that 80% of folks, when you wait for radiographic progression, you're not harming the patient. You're giving them the benefit of being on a medication that's been working. So in a sense, you're able to squeeze as much benefit from that drug, and which allows them to have that progression-free survival. And then you switch them later on, which you're maximizing all your drugs, because we don't have limitless drugs. And so I think that's how I tend to look at where I start, volume. You're looking at PSA progression, looking at preferred imaging progression before I switch them.
Gotcha. So, Dr. Chan, just out of curiosity, so on the Aerosens trial, of course, about 70-80% of those patients had what they high volume and what they called high risk disease. They were all given ADT and docetaxel, and then they randomized looking at darolutamide, which showed that there was an improved overall survival in those, mostly those both high and low volume, but in high risk disease too. Did that trial really change how you manage these patients? Do you use the sort of triplet, if you will, regimen? And in what patients would you use that?
Yeah, I mean, definitely that the data was compelling because it did have a survival advantage. And so, whenever you see a patient, when they meet the criteria, you're definitely thinking about it. I think in the real world, though, the limitation is not so much patients meeting that criteria, but the patient factors in front of you, older people, comorbidities. I think that's the main limitation of recommending triplets rather than doublets for me.
And you too, maybe a quick answer on that.
Yeah, I've just anecdotally have had a little trouble with neutropenia with that regimen. And so I'm pretty careful using it in younger, fit patients, and I will almost always use growth factor right out of the gate.
Jose, any quick answers?
I think we're lucky at our center that we see such a high volume of prostate cancer patients. And, I think, I always tell my patients, these are the things that we need to watch for, obviously the weakness, the neutropenia and these things. But by and large, I don't, look at a patient's age. So I've given chemo to 85-year-olds who seem to tolerate it well. And definitely the young guys are probably going to do even better. So fortunately, we haven't had, hospitalizations that are outside of the norm. So I think it's a very well-tolerated regimen. I think if you're giving growth factor, to Scott's points, I think you're going to be able to get these patients. And like I always tell my patients, you're going to get that survival, which is a year plus on the end of that, which is quite compelling to Doctor's point here. So, I tend to be very aggressive with our patients in terms of that regimen. And at some point you will find somebody that has maybe some other comorbidities, maybe they're on dialysis or have some cardiac issues, but I think age alone is not disqualifying.
I think most of the side effects were all kind of, docetaxel related on the trial anyway. Okay, so let's kind of switch gears a little bit and go to the metastatic castrate-resistant space. And just starting out, as sort of a little bit on the side, but the Peace 3 trial looked at patients that, and granted, maybe these aren't the patients we're seeing so much these days, patients that were on ADT for a while, and then they became, that were metastatic, but then they became castrate-resistant. And then on that trial, they compared enzalutamide to enzalutamide plus radium. And they showed that the radium is improving sort of median overall survival for those patients. Does that, at least off of trial, how have you reconciled that in your practice? Scott, we'll start with you. Has that changed Granted, most of these patients aren't like that, but do you feel maybe more compelled to adding in radium to enzalutamide up front for even patients that maybe might not fit that piece 3?
It's not something that I do a ton. I think if they had painful bone mets, I would be way more inclined to consider it. We don't have a lot of patients now that show up, progressing on Lupron alone, but I think symptomatically I would consider it if they had painful bone mets. If not, I don't tend to use a ton of radium.
Sure. And is that true for yourself?
Yeah, I mean, for radium, one is access, I think, is always a potential barrier for us, access for patients. And your systemic therapy are fairly effective in controlling those symptoms. And so if I have symptomatic bone mets, we typically would do palliative RT would be sort of top of mind for that.
Okay. And Jose, do you have any?
Well,
In our practice, just as kind of set, we do have a lot of trials, and so there's kind of, they sometimes we push patients towards the trials rather than doing something off of trial like a radium and enzalutamide. But
right. So it's really about individualizing the treatment to the individual patient, and I think that, I tend to tell my patients that, prostate cancer, by and large, metastatic, castrate-resistant, you're not dealing with disease that's curable. So what you're trying to do is you're trying to maximize the currently available options. And so it's really about sequencing drugs in a way that gives you the most opportunities at the cancer, right? And that you maximize all the drugs available. So in the right patient who comes in, who's, symptomatic, as Scott says, and who's maybe not motivated to do chemotherapy, then that might be the right patient to, give radium with enzalutamide. And then you can still do, lutetium later on. You can still do chemotherapy. You can do, docetaxel first, then you can do cabazitaxel. Then you throw in, the PARPs, and then you throw in the immune therapy, and you throw in trials. By the time you have a list that's very long in that patient. If you don't maximize that drug at that point for that particular individual patient, you may not be able to go back to radium and find the success at that point, at that juncture. And, I think you want to also make sure that you take into account that, the patients also need bone marrow reserve. So you don't want to overuse these drugs because then you may disqualify them for later drugs. So, you're looking at, one, do they meet criteria? Are they the right patient? How do you want to sequence? What is their bone marrow reserve? What is their age? And, overall, it's just trying to maximize their treatment opportunities throughout their journey.